Good afternoon. On behalf of the Department of Pulmonary Medicine, I welcome you all to today's clinical combined round. From our side, we'll be presenting a slightly atypical, different type of a case, something a little different from the run-of-the-mill diagnostic problems that we get. This patient had recurrent acute episodes of respiratory failure. He had a long course, most of that before coming to our place. And then finally, through a lot of investigations and other things and other inputs, we were finally able to get to the diagnosis and treat. So for the case, I'll be asking Dr. Jagbir to start off, and then we'll take it from
there. Good afternoon, everyone. Today we will be presenting a case on recurrent respiratory failure, a condition that poses a significant challenge to our diagnostic and therapeutic approaches. Let's delve into the journey together. So we have a 16-year-old male resident of Madhya Pradesh, who is a student. He first was admitted with us in October 2022. He presented in emergency room with chief complaints of sudden onset swelling of face and both the upper limbs and sudden onset severe shortness of breath for 1 day. He had a swelling of face and both the upper limbs for around 1 day, which was acute in onset within minutes. It was associated with some prodromal symptoms, that is nasal stuffiness, and sequentially involved lips, face, eyes, and both the upper limbs. It was asymmetric with more on the right side of the face and upper body, and it was associated with choking sensation and severe shortness of breath. However, there is no history of any triggers and not associated with any rash. Coming to the shortness of breath, it was acute onset, MMRC grade 4, rapidly progressive and required mechanical ventilation. It was associated with dry cough, choking sensation and wheezing. However, there were no specific aggravating factor. Patient says that it had some partial relief with nebulization of bronchodilators and IV medications. There is no history of any chest pain, hemoptysis, orthopnea or paroxysmal nocturnal dyspnea. There is no history of fever or ingestion of foreign body. Coming to the other history, there is no history of any intake of drugs, no history of any exposures or activities in the 24 hours prior to the onset of symptoms, no history of contact allergies to any chemical, dyes or detergents, no history suggestive of any systemic rheumatological illness, and no constitutional symptoms and other extrapulmonary symptoms. Deep diving into the history, patient had similar attacks since 2021, which were acute in onset. They used to last for around 24 to 48 hours. With treatment, they used to last for around 6 to 7 hours. These episodes used to occur 6 to 7 times per month, and patient has visited more than 100 times in different hospitals for the same attacks. According to the patient attendants, onion and turmeric was some associated with the onset of few of the attacks. The severity of the attacks was such that patient has been mechanically ventilated around 8 times in last 2 years. And patient relieving factor says that he used to get some relief by taking diphenhydramine tablets and oral steroids tablets. These episodes used to be more during the seasonal change and humid months, especially during the July. So on some of the occasion, it was associated with itchy rash. However, we don't have any documentation of the same. There is no comorbidities or other relevant past history. He was evaluated in the lines of anaphylaxis in outside hospital, where absolute eosinophil count and total Ig was normal. Pulmonary function test with bronchodilator reversibility was normal. However, a skin prick testing was done, which showed that he was allergic to multiple antigens. Based on the results, he was started on some subcutaneous immunotherapy for around 3 months in 2021. The prescription is not available with it, that which antigen was used in vaccine immunotherapy. However, there was no response in the reduction of the attacks. Later, he was switched to high-dose cetirizine, montelukast and oral steroid, which he received till October 2022. Earlier, the attack frequency was around 6 to 7 times, which he reduced to 4 to 5 times per month with the treatment. He is a non-smoker, bowel bladder habits are normal. He has been a school dropout since 2021 due to the recurrent attacks. There is history of significant weight gain and mood changes on medications, likely due to the steroids. There is history of snoring and frequent awakenings in the night due to the clinical OSA due to the increase in weight gain. However, there is no family history of similar attacks, asthma or allergies in the family. No other comorbidities in the family existed. On examination, patient was hypertensive. On respiratory examination, patient had bilateral diffuse biphasic wheeze. Rest of the systemic examination was within normal. The characteristics of edema was that it was a non-gravity dependent, asymmetric with a diffuse margin, non-pitting edema involving the lips, face, tongue, periorbital areas and bilateral upper lip. On earlier routine investigation, patient had a 0 eosinophil count. Transaminitis was there with USG abdomen showing grade 2 fatty liver, likely due to non-alcoholic fatty liver disease. There was the hyperglycemia and dyslipidemia likely due to chronic intake of the steroids. However, chest X-ray and CT chest was done, which was normal. So, based on the history and investigation, an initial differential diagnosis of angioedema, likely hereditary or mast cell mediated, anaphylaxis, recurrent acute asthma, and vocal cord dysfunction was kept. Patient was given during the attack in the emergency room injection epinephrine, diphenhydramine, and injection hydrocortisone for the acute attacks, and nebulization of bronchodilators and inhaled steroids. However, patient had only partial improvement with this, and patient received 2 units of fresh frozen plasma in the ER only in view of suspected hereditary angioedema. After admission, injection hydrocortisone, injection diphenhydramine, and nebulization of bronchodilators and inhaled steroids were continued, and tablet montelukast were also added to cover for the these acute episodes. Patient improved with the treatment and extubated on the next day. Coming to the diagnostic evaluation, to rule out the various causes which we have kept earlier, to rule out hereditary angioedema, we need to do 2 tests, C4 levels and C1 inhibitor level. However, these could not be done during the acute episode as patient has already received fresh frozen plasma in the ER. To rule out mast cell angioedema and anaphylaxis, total IG was done, which was normal. However, skin prick testing and mast cell tryptase could not be done as patient was already receiving high dose steroid from outside. To rule out acute asthma, acute recurrent asthma, total IG was normal. As a general routine workup, we also do ABPA workup in those patients who have uncontrolled asthma, which was also negative. To rule out vocal cord dysfunction, basically during the inspiration, vocal cords get abducted. However, in case if there is any dysfunction, there is adduction that can be observed in the laryngoscopy. However, indirect laryngoscopy post-extubation was normal. So, to give a brief idea about the 2 pathophysiology of angioedema, the angioedema can be mast cell mediated or kinin mediated. On the right hand side, we can see the mast cell pathway, which can be activated by various neuropeptides, drugs, complement pathway, or IG mediated allergens, which lead to the release of histamine, tryptase as a immediate phase reactants, and prostaglandins and leukotrienes as a late phase reactant, which ultimately leads to vasodilation and increased vascular permeability, leading to the angioedema. On the right hand side of the image, we can see that C1 inhibitor controls 3 pathways. One is the coagulation pathway, one is the fibrinolytic pathway, and one is the kinin pathway. So, if any pathology which decreases the C1 inhibitor levels leads to the increased production of bradykinin, which ultimately binds to the B2 receptor, leading to angioedema. Here is a table which showing the differentiation between the histaminergic and bradykinin mediated angioedema. In our patient, mast cell mediated reaction like urticaria, flushing, pruritus, throat irritations, and hypotension were not prominent. However, onset and onset was the suggestive of histaminergic angioedema. There were no apparent relationship between the trigger and onset. Family history was negative. All the complete diagnostic tests were not done because of the many reasons as explained. And patient was not showing long-term treatment response to antihistaminics and steroids. So there was a doubt whether it was mast cell angioedema or bradykinin mediated angioedema. So at the first admission, we provisionally kept a diagnosis of hereditary angioedema more than mast cell mediated angioedema with recurrent respiratory failure and Cushing syndrome, which was iatrogenic because of the long-term intake of the steroids. Patient improved after a few days and he was discharged on high dose of antihistaminics and montelukast with the tapering doses of prednisolone. He was given a specific advice that during the time of acute attack, he has to take tablet visolone and diphenhydramine whenever the prodromal symptom starts. And he was also advised to collect 5 ml of blood in the serum or in a red cap vial within half hour of the attack and to send for the serum C4 level, C1 inhibitors level, and mast cell tryptase. After that, he was followed up in the our OPD. During the OPD follow-up, tablet cetirizine and tablet montelukast in the high doses were continued. See, this is the first October 2022 was the first visit. In November 2022, in view of a suspected hereditary angioedema, we started the patient on danazol, which was later switched to cyclosporine in April 2023, which was further switched to Depson in September 2023. These all 3 are the drugs which are used in case of refractory angioedema. However, patient had persistent 2 to 3 episodes per month despite all the treatment, and he was admitted with us second time since September 2023. Here the history was again similar with acute onset facial swelling with shortness of breath for 1 day. However, we got lucky this time that patient had a rash for 1 day, which was painless erythematous rash, acute in onset, concurrent with the swelling. It started on the trunk and minutes later progressed to involve entire back also. It was associated with intense pruritus and flushing of the involved skin. The examination of rash showed erythematous eruptions associated with flushing. It was diffuse and ill-defined. The scratch marks were present over the involved areas. The area of the body involved were trunk and the back, and there were no local signs of inflammations were observed. So we learned from the mistake that we did from the last time, and this time C4 levels and C1 inhibitor levels during the attack as well as during off attack periods were available. However, all the reports were normal. This rules out the hereditary angioedema. Again, mast cell tryptase could not be sent as patient was already receiving high dose steroid from outside. So a final diagnosis of mast cell mediated angioedema was made, which was refractory to high dose of antihistaminics and steroids with recurrent type 1 respiratory failure and steroid induced Cushing syndrome. In view of refractory angioedema, we have started the patient on a trial of omalizumab, 300 milligrams subcutaneous every 4 weekly for around 6 doses. Patient had no more attacks after 2 doses of the omalizumab. Cushingoid feature improved, and patient has been off steroid for more than 6 months. Patient has a better quality of life and again joined the school. As you can see in the photo also, that patient has improved significantly. After 6 months of the omalizumab, we tried tapering for omalizumab. However, patient had recurrence of the symptoms, and the omalizumab have been restarted after 2 months of stopping, and he has been doing well after restarting. So thank you. Now I would like to invite Dr. Pranay to discuss regarding in detail the pathogenesis, diagnosis and management of angioedema. Thank you.
Good afternoon, everyone. I'll be discussing regarding the existing literature in the angioedema. So with the above case in mind, let us dig into the literature. So coming to angioedema, angioedema is a transient vascular reaction of deep dermis, mucosal or submucosal tissue with a localized increase in vascular permeability resulting in the most common symptom, which is the swelling. This increased localized permeability is either caused by bradykinin or other mediators like histamine. So accordingly, it is classified into bradykinin mediated or histamine mediated, which is synonymously used as mast cell mediated, and it is again subclassified into different types. So when it comes to bradykinin, most commonly inherited forms are most common with deficiency in C1 inhibitor levels or qualitative defect in C1 inhibitor levels, or there are other instances where angioedema can be hereditary with normal levels. These occur due to mutations as stated here. And coming to mast cell mediated angioedema, it can be either IgE mediated. So these are the mutations which can lead to angioedema, which is inherited, hereditary with normal C1 inhibitor levels. So then again, coming to mast cell mediator angioedema, it can be IgE mediated or non-IgE mediated. So coming to epidemiology and pathophysiology, hereditary angioedema is more rarer than histaminergic angioedema, as it is autosomally dominantly inherited, and it is seen in 1 in 50,000 patients. And as we have discussed earlier in the pathophysiology in the flow chart, hereditary angioedema has intrinsic defect in the C1 inhibitor levels, which checks the production of bradykinin from its precursors. So a deficiency will lead to production of bradykinin which is unchecked and with which the symptoms occur. Histaminergic angioedema, on the other hand, is most commonly associated with chronic spontaneous urticaria with a wheal. So coming to when to suspect a patient with angioedema and the clues in the history can give us regarding the etiologies. So when a patient presents early in the childhood or in the early adolescence period, occurrence of any upper airways symptoms like hoarseness of voice, change in voice, dysphagia, or any prodromal signs or symptoms before swelling, then one can really go through and look into histaminergic angioedema. Although airway edema is also present in hereditary subtypes, but in hereditary subtypes, there is a strong positive family history with a failure which is documented to antihistamines, glucocorticoids, and even at times epinephrine. And classically, this has absence of any skin rashes, that is wheals, and there might be recurrent painful abdominal symptoms when abdominal mucosa is involved. So coming to diagnosis, when a patient is present to us in an emergency department or an OPD with recurrent episodes of angioedema, so one should always keep in mind that it can be hereditary. So initially we go along to rule out that hereditary form. So C1 inhibitor protein levels and C4 levels are to be ordered. If they are low, then there is high possibility of hereditary angioedema and patient should be treated in lines of hereditary angioedema. But if the C1 inhibitor levels are normal, then patient can be having different types, that is hereditary angioedema with normal C1 inhibitor variant, or any drug induced angioedema, or with histaminergic angioedema, which will usually respond to antihistamines. So coming to the management, there are two sets of management here. One is the acute management and the chronic management. The acute management will happen mostly in the emergency department or emergency rooms. So the few possible differential diagnoses when a patient present to us with angioedema would be these. One is anaphylaxis, one is histaminergic angioedema, and the other is non-histaminergic causes of angioedema. So one should be very careful about examining the patients. Patient should be initially examined for any hypoxia or airway symptoms such as stridor or hoarseness of voice. And if at all there is hypoxia or any presentation of upper airway symptoms or lower airway symptoms, then patient should be given supplemental oxygen and an inspection of the upper airway should take place. Any incidence of laryngeal edema or lingual edema should right away instruct the physician to take the patient for an elective intubation, which is often awake intubation is preferred using fiber optic laryngoscope or bronchoscope. But keeping in mind, often these patients will have a difficult airway, so intubation might not always be possible at the presentation. So initial preparations of a cricothyrotomy should be prepared, and the cricothyroid membrane should be identified and pre-anesthetized. So coming to the hand-in-hand therapy with the acute pharmacological management goes with injection of epinephrine, histamine antagonists, and corticosteroids. Initially, epinephrine and histamine antagonists are given. If at all patient doesn't respond to these two, then you can go and give a shot of IV corticosteroids. Generally, histaminergic type patient will respond to these medications. If at all a patient does not respond, then definitely one should keep in mind that hereditary angioedema is an entity which can be there. So as the pathophysiology indicates, there is a deficiency in a C1 inhibitor. So basically supplementing C1 inhibitor will bring down the symptoms, but C1 inhibitors which are exogenous are not readily available in the emergency departments. So fresh frozen plasma can be used. So it is said that 1 ml of fresh frozen plasma contains 1 unit of C1 inhibitor. So supplementation with this can relieve symptoms. And coming to the other modalities of management of hereditary angioedema, it can be short-term prophylactic treatment and long-term prophylactic treatment. Short-term prophylactic treatment is given when we anticipate that patient with a history of angioedema, hereditary angioedema, will have angioedema, like in stressful situations like any surgeries, any emotional breakdowns, or any other reasons which can lead to exacerbation of underlying disease. So, and long-term prophylaxis will require continuous administration of C1 inhibitors through subcutaneous routes. So coming to chronic management of histaminergic angioedema, the first line agents are antihistaminics, mostly second generation antihistaminics, which can be used in standard doses or two-fold dose. If at all patient has persistent symptoms for the 2 weeks after administration of these doses, then the dose can be increased up to 4-fold dose. And if there is no improvement with 4-fold dose increase, then you can add H1 blockers or montelukast. And if at all there is no response to even these, you can add a short-term course of corticosteroids. If the patient is refractory to all these medications, then the add-on therapies or other modalities of management can be omalizumab, cyclosporine, and dapsone. So there is very less data regarding dapsone and cyclosporine regarding the treatment of angioedema, and these are most commonly used in when antihistaminics at high doses fail, and these have more side effects of use. So coming to omalizumab, we don't have many RCTs or studies stating the use of omalizumab in these patients. There are numerous case reports, but there is one RCT comparing patients with omalizumab to placebo. These are already patients on high dose of antihistaminics. So with use of omalizumab, there is a significant improvement in the angioedema activity score, and there is decrease in the number of angioedema episodes per month. Um, Coming to the discharge and follow-up of these patients, in case of acute episodes and acute discharges from the emergency department after observation for significant time, so patient, if there is an unknown etiology for underlying angioedema, then one should discharge the patient with injectable epinephrine. Patient should be taught how to use the epinephrine pen, so that it will give few minutes to hours to before the patient reaches to ED again. So from there, the patient should be discharged to an allergy specialist so that underlying etiology can be evaluated and managed. In case of chronic management, complete symptom control is the main goal. When the patient has complete symptom control for nearly 2 months, then we can start tapering the antihistaminics and steroids. Here, the proposed omalizumab tapering can be two types, which is abrupt tapering, or which can be prolonged tapering over increasing the dosage period over 1 week. And if this as this patient relapse very frequently, a close follow-up is warranted. So coming to the take-home points, so angioedema with recurrent respiratory failure is an uncommon entity, but a detailed history will give us important clues regarding the etiology. The presence of family history will indicate more towards hereditary angioedema. The presence of a skin rash and other allergic symptoms will point towards an histaminergic type. Coming to acquiring investigations such as mast cell tryptase, C1 inhibitor levels and C4 levels during attacks is needed to confirm the diagnosis of either anaphylaxis or hereditary angioedema. Coming to patients with antihistaminic angioedema will usually respond to the antihistaminics, not for routine dosing, but for an increased dosing of 4-fold. So one should, before considering any other treatment option, one should consider high dose of antihistaminics, then after followed by other treatment modalities which are described. So omalizumab is one of the most useful drugs used in these situations, and it has shown benefits in many case reports and in the RCT also. So symptom control is the final goal of therapy, and as most patients relapse very frequently, so a close follow-up is needed for this patient. So this I thank you, and I would like to thank Department of Dermatology, ENT and Radiology for their valuable inputs in managing and diagnosing these patients. Now I would like to invite Dr. Pavan.
First thing that goes without saying is just want to thank the residents who were involved in managing treating this patient, because I mean those are they were the people actually who helped us, for all the team that was involved in diagnosis and treatment of this patient. The other thing is that Dr. Vishal Gupta from dermatology was actively involved in treating him. So I would like, if you want to say something, please. And subsequently, the case is open for discussion.
Thank you. So this was a case of recurrent angioedema affecting not only the skin but the respiratory tract as well, which led to recurrent anaphylactic episodes. In dermatology OPT, we do see these patients recurrent angioedemas without urticaria, and then also we struggle with this problem, whether are we dealing with histaminergic angioedemas or hereditary angioedemas. So we also follow these clues. Lack of response to the conventional treatment, antihistamines, epinephrine, steroids, that is a very strong clue. And I'm not talking about prevention of recurrent episodes. That may or may not happen with these drugs. I'm talking about the treatment of that particular acute episode. If these drugs are not working for the management of the acute episode, then our suspicion for hereditary angioedema is very, very high. And we generally get these tests done, C1 esterase inhibitor and C4 as a screening test. So this case turned out to be of a histaminergic angioedema, and then history taking is very important. What is the trigger that is causing the mast cell to release all these mediators? And I think this was probably an idiopathic histaminergic angioedema. This patient underwent skin prick testing when there was no contributory history. And if we can look at that skin prick test result, there were a lot of allergens that came out to be positive. So that is the usual picture. The skin prick test is extremely sensitive, it gives a lot of false positive results. So in the absence of a proper clinical history, we generally do not go for skin prick tests, because even withdrawing those allergens doesn't really help, because these are largely false positive tests. So this patient actually underwent immunotherapy based on the results of skin prick test, which did not help. So that is what the expected outcome is of doing skin prick tests without a proper clinical history. So we would probably not have gone with that. Just in the absence of contributory clinical history, we would have labeled it as idiopathic angioedema. The second point I want to discuss is about the treatment. So the acute episodes, of course, the patient required proper IV steroids, high dose antihistamines, and even ventilation. Now, in preventing the recurrent episodes, cyclosporin is a good drug which we have used in the past, and it does help when 4-dose antihistamines are not really helpful. We have some patients on omalizumab as well, where the patient is developing some side effects, is becoming intolerant to cyclosporin. And we generally, once the patient has developed good response, there are no life-threatening episodes, then we start to taper omalizumab, and we do it every 2 to 3 weekly. We increase the interval between omalizumab injections, and generally they will find that sweet spot. For example, they will need omalizumab injection every 8 weeks or 9 weeks. So we try to continue them on that dose for a longer period of time before again trying to taper it further. The objective here is not to prevent angioedemas. The objective here is to prevent life-threatening episodes of angioedemas. So even if the patient continues to develop some mild episodes of angioedemas which can be managed safely at home, I think that can be kind of a successful outcome for these kind of patients. We also offer to our patients EpiPen, so that which is the self-injector. I don't remember any patient that has actually purchased it because it's exorbitantly expensive. Second is that it has a very short expiry. So even if they have it at their home and the patient develops an episode of angioedema, say 3 months later, the EpiPen is already expired. So we ask these patients to get in touch with a local hospital where they tell about their clinical condition, and they kind of are familiar, the doctors as well as the patient, they are familiar with each other, so that in case an emergency happens, they are able to reach the hospital quickly and they are managed there appropriately, apart from the maintenance treatment that has been discussed here. Thank you so much.
Are there any other questions? Yes, sir. Yes, sir. This is against IgE. Sir. Yes. 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 So basically, what I mean, we have used it in allergic asthma. So basically, you need to give it 2 to. It is not expensive, sir. Now it is, I think, 150 milligrams will cost 8,000. So it will, for this patient, it is 16,000 rupees a month. So in that sense, it is somewhat expensive. That for this guy, I do not know, because it has to be kind of for reasonable duration of time, for a year. Side effects will be basically those allergies or anaphylaxis that will happen in the next 2 to 4 hours. Yes, sir. Usually it should not, because but usually yeah. Usually it should not, but if that happens, I mean, not for that has been noticed, sir. But for this patient, only one study. So for chronic for for chronic idiopathic urticaria, and then which is complicated by angioedema, you have trials, but and this
So far, in long-term studies, we have been on long-term analysis. How long? More than 5 years of data is available. I'm talking about drug neutralizing. There may be other antibodies, but any antibody that is having an effect on the efficacy of the drug is that is right. But the efficacy over time has not been.
Sir, for this patient, sir, usually these allergic ones would be anybody, but the hereditary ones will be younger age, under 20. Yeah, I mean children and young adults. For example, this patient was 16, 15, 16 years old, was having symptoms for a year and a half. So I think I mean vigorous physical activity or emotional stress can sometimes precipitate events. So if he does not have symptoms worsening, symptoms worsened by that exercise, then probably he can. But I mean that is known to happen. Did not happen in this patient. Probably we'll have to rely on our history.
And then the so-called is absolutely no indication.
Strong historical proof of cause and affiliation, or even
In which case, you don't need the test. If you say, whenever I have peanuts, I get it, stop the peanuts.
thanks a lot.